To our CMEO snack, weighing the heavy burden of osteoarthritis, improving function and quality of life. This educational activity is supported by an unrestricted educational grant from Pfizer Incorporated. I'm Alan Gabowski, professor of medicine at Weill Cornell Medicine and attending rheumatologist, co-director for Clinic for Inflammatory Arthritis at Hospital for Special Surgery in New York. Today's activity is eligible for the American Board of Internal Medicine Maintenance of Certification credit and as a CME activity for MIPS improvement activities. Please complete your post-test and evaluation at the conclusion of the activity, and be sure to fill in your ABIM ID number and date of birth on the evaluation so we can submit your credit to the American Board of Internal Medicine. Over the next 90 days, actively work to incorporate improvements in your clinical practice from this presentation, and complete the follow-up survey from CME Outfitters in approximately 3 months. CME Outfitters will then send your confirmation of your participation to submit to CMS attesting to your completion of a CME for MIPS improvement activity. Today's learning objective is to integrate pain management tools for individual pain and function assessment, goal setting, and monitoring. It's important to begin by weighing the burden of osteoarthritis, a disease that affects virtually all joints in all of us at various times in our life, some earlier, some later, but ultimately all individuals will be affected either anatomically or functionally by osteoarthritis. And osteoarthritis, as its name implies, is joint pain, which causes functional limitation and loss of independence. In addition, other things such as poor sleep quality, fatigue, depressed mood can occur to the patient, resulting in increased healthcare expenditures for the care of the condition, as well as a possible surgical procedure of joint replacement. Now, another factor of osteoarthritis are the multi or comorbidities that are associated in patients with the disease. A systematic review of over 40 studies looked at comorbidities in individuals with osteoarthritis, and a little more than 2/3 of individuals with osteoarthritis have at least one other chronic condition, and that is about 20% higher than those individuals without osteoarthritis. These investigators found that the most common comorbidities are stroke, peptic ulcer, and metabolic syndrome. Further, patients with osteoarthritis are caught in a cycle of chronicity. This investigator looked at the predicted probability of difficulty walking for a 60-year-old middle-income woman of normal weight. What you can appreciate is the increased probability of difficulty walking with osteoarthritis as a function of additional comorbidities. There are a number of risk factors that may predispose to the development of osteoarthritis, some modifiable and some non-modifiable. Local risk factors include muscle strength, physical activity, inappropriate ergonomic movements, occupation, joint injury, joint alignment, and body length bone inequality. The best example I can give you as to how occupation can contribute to osteoarthritis is if you think of a young man working construction holding a jackhammer 40 hours a week. After a number of years, that young man will have the hands of someone significantly older because of wear and tear to the joints of the hand. So we can see abnormal use to normal joints or normal use to abnormal joints, increasing the risk of osteoarthritis. Diet may be a risk factor because increased weight increases the stress on the joints, thus increasing to mechanical dysfunction. There are non-modifiable risk factors such as age, gender, genetics, and ethnicity that may also lead to predisposition, as well as the systemic risk factors of obesity, which I've already alluded to, and bone metabolism. When faced with a patient complaining of joint pain, it's of course important early on to identify the anatomic location and also to assess comorbidities that may be impacting on the course of disease. Things like heart disease may not seem to be a significant comorbidity that may be important. However, heart disease may result in reduced function, and reduced function may in part lead to increased stress on bone as well as decreased bone metabolism. So one has to assess the clinical status of the patient, assessing pain, function, stiffness in the joint, effusion, instability, and malalignment. In addition, one also has to assess the emotional status of the patient as well as the environmental status or social support. The social support and social network of any patient, and in particular the older patient with osteoarthritis, is important. Health beliefs and expectations may be important, as well as sleep quality in given individuals as well. Quantitation of symptoms is particularly important in assessing not only disease activity, but also in assessing response to therapy. And it's for that reason that a number of assessment tools are often used in patients with osteoarthritis. The PEG score, which is a very simple 3-item scale asking about pain, enjoyment of life, and general activity, can be a very nice way of defining where the patient is when first seen and also during the course of therapy. In addition, there have been a number of psychosocial impact scales developed as well, such as the GAD-7 and the PHQ-9, which also assess anxiety and depression. Admittedly, these scales are less often used in routine clinical practice. In clinical trials, certain other outcome measures may be useful as well. You may see patients required to have a certain KOOS score, the knee injury and osteoarthritis outcome score. And this is a patient-reported outcome about the knee and associated problems over the short and long term in the follow-up of the patient. There are a number of domains assessed and measured on a 5-point Likert scale from none to extreme. In terms of assessing pain frequency and severity, knee stiffness or presence of swelling, clicking or range of motion restriction, difficulties with activities of daily living, difficulty with sport and recreational activity, and knee-related quality of life. The KOOS PS is a modification of the KOOS and a shorter form looking more at routine activities of daily living in which the patient may report difficulties experienced with physical activity, such as rising from bed, putting on socks, risking activities from sitting, bending, twisting, pivoting, kneeling, and squatting. Again, the 5-point Likert scale is used. And finally, there is the WOMAC, the Western Ontario and McMaster University's Osteoarthritis Index, which assesses the course of disease or response to treatments in patients with knee or hip osteoarthritis. There are subscores of the WOMAC, such as pain and function, which measure pain severity, joint stiffness severity, as well as difficulty performing daily functional activities, also on a 5-point Likert scale from none, mild, moderate, severe to extreme. In dealing with patients with osteoarthritis, it's useful to make reference to the American College of Rheumatology and Osteoarthritis Foundation guideline for the management of osteoarthritis of the hand, knee, and hip. And in this regard, there are both non-pharmacologic and pharmacologic recommendations. For example, you can appreciate in the non-pharmacologic category that things such as exercise, self-efficacy, and self-management program are helpful, particularly if combined with weight loss, Tai Chi, and the use of a cane if a weight-bearing joint is involved. Orthoses may also be useful for the first carpal metacarpal joint, the so-called hand splint, and knee bracing may be useful for the knee, which is a weight-bearing joint. There are a number of conditionally recommended non-pharmacologic management recommendations as well for the hand, knee, and hip, such as heat and cooling, cognitive behavioral therapy, acupuncture, taping, balance training, other hand orthoses and paraffin baths for the affected hand, knee bracing, yoga, and rarely radiofrequency ablation. When we move to pharmacologic management, there are additional guidelines that fall into place as well. Oral nonsteroidals appear to be useful in osteoarthritis regardless of the joint involved. Topical nonsteroidals have been strongly recommended for osteoarthritis of the knee and less so for osteoarthritis of the hand. They are not recommended for osteoarthritis of the hip. There are conditional recommendations for intra-articular steroids, as well as use of acetaminophen, tramadol, duloxetine, chondroitin for the hand, and topical capsaicin for the knee. Finally, it's important to recognize when referring to the guideline that there are certain modalities that should not be employed, and these include iontophoresis, TENS units, manual therapy, massage therapy, shoe modifications, and pulsed vibrational therapy. Further, a variety of medications that are used in other conditions are not recommended at all for osteoarthritis, and these include biologic agents, bisphosphonates, glucosamine, hydroxychloroquine, among others. Modalities such as platelet-rich plasma and stem cell injection have not really been shown to be effective in this condition. Intra-articular hyaluronic acid for the hip is strongly recommended against. Other modalities such as colchicine, opioids, fish oil, and vitamin D are not included nor recommended in the ACR Arthritis Foundation guideline for management. Our SMART goals then are to recognize the burden of osteoarthritis patient function and outcomes, monitor for comorbidities that may further impact function and quality of life, and apply the ACR Arthritis Foundation guideline to the management of osteoarthritis where and when appropriate. There are other CMEO snacks available for your reference, which can be found on the website listed on this slide. I hope you will take a moment to refer to all of them so that you can get a comprehensive assessment of the patient and the field as it has evolved. Please visit the Rheumatology Education Hub for free resources and education to educate healthcare providers and patients on osteoarthritis, as well as a wide array of other inflammatory disorders. To collect credit for this activity, please see the information on the slide. You can use that link to be directed to the appropriate location, where you will fill in your ABIM ID number and date of birth on the evaluation so that your credit can be submitted by CMEO to the American Board of Internal Medicine, at which point you can then print your certificate or statement of credit immediately.